For those of you who are interested in OCD, I thought I would offer you a summary of how it's treated. So think of three levels of care. We've got a most basic level, which is going to be medication. We've got psychotherapy, which is actually more effective than medication. And then the highest, or well, the highest level for purposes of this discussion would be the technologies that we have. So, to get started, there are several medicines that can help with OCD. Normally, we think of the antidepressants first. So, the antidepressants are a newer group of medicines called the SSRIs. That stands for selective serotonin reuptake inhibitors. They're SNRIs, serotonin norepinephrine reuptake inhibitors. Those are the we'll call them the modern antidepressants, as distinguished from clomipramine, which is an older group called the tricyclic antidepressants. And so, of those medicines, clomipramine is still considered the gold standard medication used to treat OCD. The problem with clomipramine and other tricyclic antidepressants is sedation or sleepiness and weight gain. So the sedation is normally not particularly a problem if a medicine is taken at a low dose at bedtime, but if the dose has to be taken twice a day, then you've got sleepiness during the day. Clomipramine can be exactly the right medicine for some patients. I've got a patient who's been on it for years with no side effects at all. So there is, in the SSRI family, Luvox. Luvox is also considered to be kind of the leader of the pack of that particular group of medications specific for OCD. Luvox, as an SSRI, will also help with anxiety and depression, as all the SSRIs do. In fact, they tend to work better for anxiety than they do for depression. In the context of OCD, Luvox is effective. Luvox is usually dosed initially at bedtime. The side effect to be tolerated would be fatigue. So taking the medicine at bedtime tends not to result in fatigue the following day. But then when you get up to the dosing goes technically up to 300 milligrams, but when you start going up on the dose to maybe 150 or 200 at bedtime, then it's more or less customary to try to divide that into two doses, 100 milligrams twice a day, and that's when the daytime dose starts to cause so much fatigue that it can limit treatment. In fact, in getting patients on that particular medicine, we tend to inch up the dose over time to see just what the patient can tolerate. Obviously, we don't want to cause a problem to treat a problem if we don't have to. So that's pretty much the discussion of antidepressants. Now, there are two other medicines that come from the antipsychotic family that can be useful with OCD. One in particular is Abilify, which tends to be non-sedating. The risks of weight gain and sedation are actually pretty low with Abilify compared with the other medicines in that family. Olanzapine is the other. Now, Abilify is the brand name for aripiprazole. Olanzapine is the generic name of a medicine that's also called Zyprexa. So, a very good medication used at a low dose. It can really rein in the acuity of the anxiety attached to the OCD, and as a symptom, and therefore can help rein in the symptoms. Sleepiness is a side effect. Weight gain is a side effect. Of course, those side effects don't play out with everyone, so prescribing and managing these medicines is as much of a practice of dealing with the side effects as much as it is prescribing what's likely to work. So that's pretty much the medication discussion for OCD. Obviously, there are people with moderate to severe OCD whose symptoms are not going to be well controlled with medication. Now, the second category that I wanted to talk about is psychotherapy. When patients get good psychotherapy for OCD, it actually works better than the medication. OCD is kind of centered in the brain in an area called the anterior cingulate cortex. And if you can just imagine nerve circuitry that's kind of looping around and around, it gets stuck, and so people get stuck on thoughts and stuck on fears, and that looping around gets so reinforced that it's really hard to break into. What medicine does for OCD, more than anything else, is lower the anxiety associated with the OCD, such that patients just don't have as much fear or don't worry as much about their the subject, whatever that subject is that they're stuck on or suffering with. So psychotherapy, the psychotherapies that works is thought to be exposure with response prevention, ERP. That type of psychotherapy has grown into a very effective and specific type of therapy. There are cognitive exercises that one does with the therapist and then learns to do independently. There are behavioral things that can be done. So a textbook example of a behavior that treats OCD is, let's say somebody has a cleanliness problem and washes their hands 50 times a day to the point where they're cracked and dry. Well, if we again, this is a textbook and possibly extreme, but after a trusting relationship is developed between the therapist and the client, the patient agrees to touch a toilet seat and then wait an hour without washing his hands. So the therapist is there. What the patient doesn't know or doesn't believe is that toilet seat has been sanitized to be responsible. His fear is, of course, that it's not. There are germs all over it, and that's the obsession. The compulsion then is to wash his hands. But when he's not allowed to wash his hands, then he's not able to do the very thing that lowers his anxiety about that toilet seat and having touched it. And it is literally the brain. Again, the patient is not allowed to wash his hands for an hour, and during that hour, the brain then has to tolerate the anxiety. And it's kind of like turning down the thermostat, that because the brain has to tolerate the anxiety, then there is less anxiety next time that patient is exposed to that activity or similar activity. There are, of course, less dramatic ways to do that. Therapists have people watch videos that again increase their anxiety and their fears, but they watch them together, they pause them and talk about them and process them. Apparently it's a very, very useful thing for the patient to be able to verbalize, to put words to fears and anxieties that are symptoms of the OCD, and by being able to talk about it and experience the anxiety in the moment, but then realize intellectually with the help of the therapist that you are tolerating the anxiety, you are fine. The fear is not playing out to some kind of adverse problem. Another example would be cracks in the sidewalk. Most people know that OCD people can easily have that kind of a ritual thing whereby you just have this fear that if you step on a crack you break your mother's back. Have you ever heard that said that way? But people with OCD really have a fear that something bad would happen if they did that, so they avoid stepping on cracks. So you can imagine then that an example of exposure therapy would be for that patient to go on a walk with the therapist, and how many of those cracks can we step on, and then uh, you know tolerate the anxiety of having done that and realize that nothing bad happens. Um, so you're getting an idea about this exposure with response prevention. Some of it is behavioral, but a lot of it is the cognitive work that the therapist and client do in the therapist's office. So then the third level of treatment for OCD has can be summed up as brain stimulation, and there are essentially two ways to do that. Again, just to keep it simple, there are more ways that are experimental. One is TMS. Now, TMS stands for transcranial magnetic stimulation. We have that technology here in my office. Um, the the technology of TMS is electromagnetic, such that you pass an electrical current through a copper coil. The coil is close to the patient's head. The electricity is mild enough that it doesn't go through the skull, but it generates a magnetic field that does easily go through the skull and then dissipates on the surface of the brain, leaving an electrical influence. TMS treatments are done often daily for a couple of weeks, and then every 3 days for a couple of weeks. There are various protocols, but TMS is FDA approved for the treatment of OCD. The way the copper coil is designed, there is a focus that goes near the midline down to that anterior cingulate cortex that I mentioned earlier, stimulating that. And the thought is that what the TMS does is scramble the nerve impulses in that particular area of the brain. So if you think of OCD then as it exists physiologically in the brain, think of it as loops of nerves that are just looping around and around and are highly reinforced because of how much that has happened, such that there's something kind of automatic to it. Can be very distressing to patients. What TMS does then is to kind of scramble the nerve impulses in that area of the brain, somewhat go ahead and use the word, breaking up the circuitry. That is not done in a way that's harmful. It's not traumatic to the brain, but electrically changes happen other than that simple constant reinforcement. So then if directing the TMS impulses to the anterior cingulate cortex is transcranial magnetic stimulation, there is a more invasive technique called deep brain stimulation, which is done by neurosurgeons, and it literally is a process in which an electrode is passed down into the anterior cingulate cortex. This is a procedure done in the operating room with CT scan or MRI scan guidance. I think it's the CT scans that are used now, in order to get that electrode exactly where it needs to be, and then that electrode is connected by a wire that is all under the skin and there is a unit that is programmed either on a computer or with what's called a wand to emit the level of impulses that are considered therapeutic. So that's deep brain stimulation and invasive neurosurgical procedure, and then there's the transcranial magnetic stimulation, which obviously is not going to be quite as strong, but because the DBS is invasive, it is reserved for people with severe intractable OCD who just have no quality of life at all and are not responding to any of the lesser treatments. So there you have it. We have a medication discussion, psychotherapy, and then what I call the technologies, TMS and DBS. So I hope that helps you to organize your thinking about how OCD is treated.